Hello, my name is Mr. Kiran Varad. I'm an ENT Registrar in the south of England, and today I'm going to be giving you a brief overview on common ENT emergencies. The first emergency I'm going to talk about is epistaxis, which is essentially a nosebleed. This is one of the most common ENT emergencies, both encountered in primary care but also in accident and emergency environments. The etiology is widely varied. This includes trauma, coagulopathy, hypertension, and the use of anticoagulant and antiplatelet medications. When considering epistaxis, it's very important to look at the anatomy of the nose, specifically the blood supply. The nose has a very rich blood supply, both from the internal carotid artery and the external carotid artery. One of the most common areas for a nosebleed is Little's area. This is an area in the anterior part of the nose that has a blood supply from multiple blood vessels. This, combined with the fact that it is at the front part of the nose and therefore exposed to the environment, mean that it is a common cause and site for epistaxis. More rarely, the posterior part of the nose can be a source of epistaxis as well. The management of epistaxis is through a stepwise approach. Firstly, resuscitation is required via an airway, breathing, and circulation approach. Epistaxis can compromise the airway through the formation of clots in the back part of the nose, which may then drop off into the airway. It's important to suction these clots through the oropharynx. As with any bleeding patient, resuscitation should include treatment of any hemodynamic shock. The initial steps for the management of epistaxis are conservative. One should firmly hold the fleshy part of the nose, tilt the head slightly forwards, use ice on the forehead or occiput, and wait for about 10 minutes, as demonstrated in the picture on the right. Nasal cautery can be considered in cases where the epistaxis is not severe. In cases where the bleeding does not stop, the nose is packed using a non-absorbable pack. This is usually kept in for 24 to 48 hours and then removed. Surgery is considered for cases where packing does not work. Nasal cautery can be done through various methods. The most common method is the use of chemical cautery with silver nitrate. Silver nitrate sticks are used to paint the blood vessels that are affected in the nose, and this chemical reaction then stops the bleeding. Electrocautery can be applied using bipolar diathermy, which is a surgical instrument, and the electrical cautery then seals off blood vessels. Nasal packing consists of inserting a temporary packing material into the nose to stem the bleeding. This works through the application of pressure on the bleeding site. These packs are then usually removed in 1 to 2 days after insertion. In cases where simple cautery and packing has not worked, we need to consider surgery. This usually involves cautery of bleeding points endoscopically. Sometimes a larger blood vessel that supplies the nose, specifically the sphenopalatine artery, can be located and ligated. Traumatic epistaxis is usually due to damage of the anterior ethmoid artery, and this artery therefore needs to be ligated in these cases. Very rarely, an external carotid artery ligation through a cut in the neck can be considered. The next emergency I'm going to talk about are nasal fractures. Nasal fractures are almost always associated with epistaxis, and this therefore needs to be managed as described previously. Patients may also have other facial fractures from trauma, and these also need to be excluded. Treatment includes management of the epistaxis, as mentioned. The other area we must consider is the formation of a septal hematoma. If there's any cosmetic deformity of the nasal bones, this can be corrected with a manipulation under anesthesia that is done within a month of injury to prevent the bone setting. As mentioned previously, a septal hematoma must be considered. This is a collection of blood that develops between the nasal cartilage and the surrounding mucoperichondrium and tissue. The nasal cartilage derives its blood supply from this mucoperichondrium, and as such, if the blood supply is separated by a hematoma, then one can have septal necrosis, resulting in a nasal deformity due to the death of the cartilage. Classically, a septal hematoma looks like a bilateral cherry red swelling that is compressible, as described and shown in this figure above. This requires urgent surgical drainage to prevent septal abscess and necrosis. Stridor is a serious emergency of the airway and therefore must be dealt with promptly. It's essentially a high-pitched, abnormal, harsh upper respiratory sound, and it can be inspiratory, expiratory, or biphasic, which means that it happens both in the inspiratory and expiratory phase, and this depends upon the anatomical location of the airway obstruction. Classically, stridor that is above the vocal cords or at the level of the vocal cords is inspiratory. Expiratory stridor usually occurs because of problems below the vocal cord or in the trachea, and biphasic stridor occurs in problems that affect the upper and lower part of the airway. Stridor in children is certainly a cause for concern. Epiglottitis is a surgical emergency in children. Classically, a child will be sitting forwards, drooling, be pyrexial and tachypneic, and will be using all of their accessory muscles of respiration. In these cases, it's very important not to distress the child further. This will require multidisciplinary management with the anaesthetic team, pediatric team, and the ENT team. Usually, stridor or epiglottitis in children is caused by the Haemophilus influenza bacterium. However, due to the Hib vaccination, the incidence of epiglottitis in children is declining. More commonly, stridor in children tends to be caused by croup, and this presents with a barking seal-like cough with low fever that is worse at night time. The other differentials to consider in stridor in children include anaphylaxis, a foreign body in the airway, a neck abscess, or congenital abnormalities that are compressing the airway. This is a picture of a normal larynx with the left vocal cord on the left part of the screen and the right vocal cord on the right. This is a picture of epiglottitis. What is demonstrated is a cherry red swollen epiglottis. It's very difficult to see the airway below, and this is why patients with epiglottitis struggle to breathe and have stridor. The differentials for stridor in adults include anaphylaxis, epiglottitis, which tends to be less serious in adults as their airways are bigger than children, a foreign body in the airway, abscess, and also laryngeal cancer. The management of stridor is through, again, an ABC approach. A flexible nasal endoscopy can be performed to assess the airway. This is essentially a thin endoscopic instrument that is passed through the nose to observe the airway. Adjuncts to help stridor include nebulized adrenaline and intravenous steroids. These both work to reduce swelling and improve flow of air through the airway to allow improvement in ventilation and breathing. In extreme cases of stridor, intubation may be required, and in cases where intubation is not possible, perhaps due to swelling or the presence of a laryngeal cancer, a tracheostomy needs to be considered. A tracheostomy is the insertion of a tube into the trachea to bypass any obstruction above this and allow the patient to be ventilated.